So tonight, let me go forward this. So I want to go through a few announcements that I have to make first, and then we're going to actually get to a GCAB related project, which is about renaming the ACTG network. And then I have some news about one of the trials that we helped to enroll, the Reprieve study. And then our focus tonight, I wanted to focus on Lenacapavir. We were going to be perhaps doing a study of it here in Seattle. We may not be doing that now, but I still wanted to kind of just review in our community's mind what is going on with this drug, because we've mentioned it in the past, but I think you're going to hear more and see more about it in the future. And then I wanted to end up with a study that the ACTG is thinking of taking on, which they're calling the HTX I guess they say 1004 study. I don't know how they're actually saying the numbers there, but let's go to the announcements first. And the first announcement is to people specific to Washington State. This is the Department of Health here, their syndemic planning group, and they're going to be having community focused caucus sessions. And the 4 session topics are going to be long-term survivors, transgender, gender expansive people, people who use or have used drugs, and people who are impacted by mental health diagnoses or cognitive disabilities. So they're looking for people who are at least 18 years old or older and who are living in or receiving services in Washington State. It's a $50 gift card for each 1 hour virtual session that you attend, which I think is a great deal. So I'm going to let Bill is joining us here. So I think that's a great deal. I don't know how exactly they're going to work all 4 sessions, but you can apply for more than one. I looked at the registration form. When you sign up, you get to choose which ones you think you are qualified for, and then they're going to have someone get back to you to tell you where they can actually put you into what group. So I don't know if it's a guaranteed thing if you sign up for it, if you get to, be a part of all 4 of those, but you do get to choose at least one of them. And the $50 gift card, it can be something that is mailed to you, or it can be an electronic form of a gift card as well, whichever one you prefer. Let me try to get this. There we go. So right there is the QR code. If you have a smartphone next to you, you can take a picture or you can screenshot this and it'll take you to the registration page. I'll be sending this out as an email for those of you living in the state who are interested in this. So if you haven't heard about it yet, but I just wanted to make sure that I announced this as an opportunity for people to be a part of these community focused caucus sessions, all about the syndemic planning group. And a syndemic planning group is a planning group that's trying to take care of more than one epidemic that is happening at the same time. And so they're trying to, the synchronicities between epidemics is what they're trying to create plans around. So that's why if you look back at the 4 groups that they're looking at, the long-term survivors, transgender or gender expansive people, people who use drugs or have used drugs, and people who are impacted by mental health diagnoses or cognitive disabilities. Let me try to get there. I'm in. Okay, so let me move on. So again, you can take a screenshot of that. The second announcement, this applies to everyone. This is a new webinar series that's being started in May. It's about long-term survivors and HIV cure research and all the things that will affect people who are long-term survivors or can potentially affect them in terms of HIV cure related research. And so the topics that they're going to be going through are, they're going to have an introduction to aging research in general, and then they're going to have an introduction to HIV cure research, and then they're going to be looking at issues with people who are over 50 living with HIV in terms of cure research, and then they're going to focus on specifically women's issues, and then issues for people who have acquired HIV early in life, or who are either verticals who are considered born with it or acquired it very early in their childhood. Then they're going to have an interesting one in October, participant experiences, which is going to feature the City of Hope patient who just came out recently. His name's Paul, and he's going to be featured there. So you'll get to hear from him a little bit more. And then they're going to have a session where they're going to be planning what are the next advocacy steps for long-term survivors in terms of cure research. And they're going to be leading a discussion that way. The QR code to the right there will actually link you up to the registration for these. They're all taking place on a Tuesday, but some of them are second Tuesday, some of them are third Tuesday, some of them are fourth Tuesday, but they're all taking place for people on the Pacific Coast at 10 a.m. For people on the East Coast, it'll be 1 p.m. But you can use that QR code. I've sent out emails about this already, but I'll be happy to send out again if you haven't received one and are interested in getting that. But again, it looks like it's an interesting session or sessions. And so I'm looking forward to having that. The next thing I wanted to announce is our next meeting is going to be a hybrid meeting. Definitely the place is still to be determined, but we've sort of committed, Chris and I, to having this happen in person. So we'll be meeting in person or via hybrid, and that'll be on Tuesday, the 23rd. So this is before Memorial Day, which is coming up, and it'll be at 5:30 p.m. And I still have to secure the place where we'll be having that. But we wanted to have it off there so we could eat some pizza together like we used to do and just get together physically and see each other face to face. So please, those of you living in the area, take a note of that, and hopefully you'll be able to join us on the 23rd. I'll be sending out an announcement with the place once we've determined it. And so our first topic really to go into is the potential name change that the ACTG is considering. And this started about a year ago, and it started in discussions at the last ACTG annual meeting. And partially that's around the reasons that you might be familiar with, since we changed our name to UW Positive Research. They were thinking that the scope of the network has increased. I mean, we've done COVID studies, and now we've done MPOX studies, or a study. And so we do more, of course, than just HIV and AIDS. We do viral hepatitis, we do tuberculosis. And so we were discussing whether this should be something that we look at in terms of a name change, so the group can be externally represented to people by a name that fits all of the work that we do. So the executive group, which is what the AEC stands for there, basically charged the subgroup of that group, the communications subcommittee, to lead this process. And so we've, with that group, and I'm a part of that group, so if I say we, that's what I'm meaning there. We queried many different groups on whether we should consider a name change, and we've gathered suggestions for possible options, and we tried to engage in dialogue with all the various stakeholders. And we also did collect some alternate names during these meetings, and then we've asked basically the subcommittee to narrow down the options to 3 good options. And so we tried to make this a fair process, and we tried to make sure that we're getting all of the feedback that we can possibly. So you are some of the stakeholders that we want to hear feedback from. And so Manuel, who is our GCAB rep, asked me to bring this in front of you all so you can give us your opinions on the suggested names that they have. And so without further ado, we'll go over here.
And Michael, can we just also add too that actually part of, I think, the inspiration to do this at the network level was the report back of the process that we did locally, and the beautiful new logo and the beautiful new name, and the process that we came up on it came through it. I mean, obviously people at the network were thinking about this before June, but I just want to say that like you all and what we've done together actually really inspired this at a national level too. So I think that's really cool.
Well, I thank you for saying that. I didn't want to say that because I felt sort of like, like I just was kind of assuming that might have been in there, but I think it did inspire a change. And so here is the suggested changes so far as they've been coming to us. And you'll see that they're not really looking at a broad name change, because right now the ACTG network, they're looking, at least people were trying to keep the same letters. So before it's AIDS Clinical Trials Group, and now they're looking for new meanings of that. And Manuel, I don't know if you wanted to say what we're going to be doing or add any of your own thoughts to this.
I would like to spend the next minute or two to for all of us to read through these options. And there is also the option number 5, which is to suggest additional names as well. The CAB input will be sent to the Global Advisory Board after this call so that all the sites have gotten their responses submitted in time before the June meeting in person. And the next step from the CAB input would be that the executive committee will have all the options laid out in front of them in June, and then there will be a decision after the annual meeting.
Right. And as well, everyone should realize also each site gets a vote. So in other words, Rachel as our leader would be representing us and give one vote from the University of Washington site. And every site like that gets to vote, have one vote like that as well. So there's going to be a lot of people's votes, but this is the chance for the community to vote. And we would like to hear from everybody for this, because this is something they wanted to know. If we have disagreement in terms of what we think is the best, they want to know how many people have voted for 1, how many people voted for 2, how many people voted for 3, how many people voted for 4, and if there's other suggestions as well. So that's the way I would love to be able to record this. And so I don't know if people, let me see if I can't. No, I can't. Where is, I'm trying to get my power bar down so I can see the participants. Whoops, sorry, and that's not what I wanted to do. Laurie, go ahead.
So what about a hybrid of 1 and 2, changing therapeutics, which is kind of a fancy word, to trials, which is what the ACTG does,
Right.
and have it be advancing clinical trials globally for HIV/AIDS and other infections?
That's a great suggestion. So taking trials, so getting rid, basically just changing the first one, but getting rid of therapeutics, which is fancy. You're indeed right.
Yeah. How much? I mean, I know the network was used a fair amount for COVID. I assume the ACTG feels like it does substantial research now that's not HIV related, that the name should incorporate the broader scope.
I think there are some that feel it or would like that. I don't think that's a uniformed feeling, given the discussions that I've heard, where some people feel like the name doesn't need to be changed at all, or they feel like the tag that you can see there. So like the ACTG would be advancing clinical trials globally, and then for HIV/AIDS and other infections is like, where they're going into that. I mean, they could put all of the viruses or all of the infections that they deal with, because they're dealing with hepatitis and tuberculosis, and we've traditionally been doing that. And now we can add COVID or SARS-CoV-2 and Mpox to the list. But that's where the HIV and other infections.
I wonder if there's a word that's better than other.
Yeah,
Others kind of.
It doesn't seem to me like it gives. I was arguing that it does, other just seems like it's too condensed.
Maybe related or
Yeah,
co-occurring or
yeah. I
right.
didn't come up.
Right, the ACTG isn't just gonna pick up on like every infection that's out there. So is there something that kind of defines the scope of?
It seems like number 2 kind of gets at that because it's global infections. It's essentially, I mean, I think the list of infections that ACTG will work on is kind of either co-occurring with HIV or understudied, underfunded, neglected, like TB and hepatitis, but are of huge global importance.
Right.
So I wonder if option number 2 sort of gets it at that need.
So then maybe if you were to do that, then you could do the second one, but take out adult and make it advancing.
Yeah, you could still mix 1 and 2, I think, is probably what you're saying, Lori, is that right?
Although
Advancing clinical therapeutics
I don't,
or advancing clinical, I don't know, trials. People have had challenges with trials globally or for HIV and global infections.
yeah, although I think advancing works better in the first one than going.
Yeah, well, no, that's why I was trying to mix number 1 and 2 just in a different mix than you included.
Yeah,
Hmm.
you don't want to.
How, can I just ask, Michael, 3 doesn't seem to go with, is the ACTG, is the idea that the ACTG would, the G is global?
Well, so I don't know I can't say what's going on with the third one, except that obviously the letters don't represent anything.
Right, no.
You know what I mean? Like, it's supposed to be
yeah,
like-
that's why I was curious.
Yeah. So the other one's confusing in terms of the first 2 are trying to fit ACTG into a new meaning. And then the third one is just sort of like using ACTG as the letters, but then saying that it's really, that's what it stands for. It doesn't.
I see.
It
It
doesn't
doesn't,
work.
so the ACTG doesn't stand for anything there.
No. Like, and that's what to me personally makes this third one weak, because it doesn't seem to make sense why they would say ACTG, Global Clinical Trials Network, except that's what they're trying to like. They're trying to make, I think, the ACTG would just be letters. In other words, kind of like how NMAC used to be the National Minority Council on, or Minority AIDS Council, and then it became NMAC, and they just go by NMAC. You know, like, and it doesn't represent anything anymore. So it might just be that ACTG is supposed to be like that, and then the whole subheading is that they're a global clinical trials network for HIV, AIDS, and other infections.
Got it. Thank you.
Yeah, but that third one doesn't work as smoothly. You know, I think there needs to be some work with that.
I think number 2 says it all.
You like 2, Bill?
Yeah, I think it's short. You know, you don't want it so long, you know, that at number 1, you know, therapeutics, what's that?
Right.
You
Can
know,
they, and the problem is if you substitute something for therapeutics, then like trial.
Are you there? Hello? Can other people hear?
Does the ACTG do any pediatric studies, or is that all through a different, is the pediatric network different?
Yeah, that's IMPACT, IMPAACT, which is like International Pediatric AIDS and something clinical trials.
Yeah.
I don't know what their second
Adolescents.
A is. Adolescents. Yeah. Yeah. And so I think, I mean, adult is truthful, but to me it just sounds cheesy because it doesn't feel very specific. Like, we do studies on adults. It doesn't, I don't know, it doesn't sound pizzazzy to me, but that's just me.
What do you think about related infection? I think if we put trials in place of therapeutics, I would like the first one better. But what do you think about related infections?
Here, I'm going to share
Good
the screen
idea
again.
about that.
Okay.
That's nicer. I think it gets rid of the concern that, like you're saying, like other is like othering or less important. It makes it feel
Michael, can you go
co-important.
back to the names?
Yeah, hold on. Let me I want to share again. Hold on. Let me get this. Oh, no, hold on. I lost the slideshow. There it is. All right. Let me get this. And screen share. And so this is that.
So what are they suggesting one would look like changed?
I'll put it in the chat.
Okay, yeah, put it in the chat.
I just want to say too that my PI vote will be whatever our community wants. So it'll be like the electoral college, but hopefully more functional.
Better be more functional.
More representative.
And so Laurie, you're gonna put that in the chat, you said.
Yeah.
There it is. She did.
Okay, cool. So if everyone wants to like take a chance, and why don't you just give us like number 1, number 2, number 3, number 4, or if you like what Laurie's written on the chat, you can just write Laurie's suggestion. Just put your vote in the chat of what you think you would like to see, or if, and remember, you can say no name change, or you can just even say I don't like any of these and just leave it at that, whatever you want to say. But I'll tally that up, and then Manuel and I can send this on to the GCAB reps behind this, and we can make sure that voices are heard. So I also wanted to get into some good news. We have news from the trial that we haven't talked about in a while, which is the Reprieve study that we did. And the news is that it was stopped early because the trial medication, which was a daily statin medication, was found to reduce the risk of cardiovascular disease in people living with HIV. So this was stopped not because of futility, but because it worked. It was seen as efficacious. And so this is really important because this is the first clinical trial that was studying a preventative approach to cardiovascular disease among people living with HIV. And these people who were enrolled in this study were considered to be at low risk to moderate risk of cardiovascular disease events like a heart attack or a stroke. So this was a planned analysis that was happening in the middle of things. And it was found that the participants who got the drug, which is pitavastatin calcium, which is a daily statin pill, and it reduced their chances of major adverse cardiovascular events by 35% compared to the people who were taking placebo. And so Reprieve's independent Data Safety and Monitoring Board recommended that the study be stopped early, and the National Institutes of Health, where we got money to do this from, accepted this recommendation. So we really played a big role in Reprieve. It began back in 2015, and lots of the ACTG investigators had key leadership roles in this protocol. And 52 ACTG sites enrolled more than half of the total participants, which were 7,769 total. These participants were all from 40 years of age to 75 years of age, and about 30% or a little bit more than 30% of them were women. All of them were on antiretroviral therapy, and they all had CD4 greater than 100. And again, they had low to moderate risk for cardiovascular disease events. And so they wouldn't normally typically be considered for statin treatment. So we were thinking about this as a potential treatment before there's problems. This was conducted in 12 countries in Asia, Europe, North America, South America, and Africa. And, you know, so statins are already known to work for people who are at high risk in the general population. But this study was looking at it as if it was if it would work in people living with HIV. So especially people who are not traditionally candidates for statins, who are at low to moderate risk. But we know that people living with HIV often experience premature heart disease events. And so this was really an important way for us to improve these outcomes for people living with HIV. And so this is good news. And this is the study's vice chair, Carl Fitchenbaum. And he basically said it was incredibly gratifying to see these results and to know that this study has the potential to change clinical practice and thus have a meaningful impact on the experiences and health of people living with HIV. And then he goes on to say, you know, that this has been an area of research that's been a priority for the ACTG for 20 years. And he was congratulating the people involved, including the dedicated study participants who've contributed to making Reprieve such a success. And when I think of those people, it makes me think of these people. So we were a part of this. This is a video that was made by the National Institutes of Allergy and Infectious Disease, and it was made around CROI that was in Seattle that year, and it was made on Valentine's Day. And the guy on the right is Karl Diefenbach, who's the director of the Division of AIDS, and the people on the left were 3 of our community members involved with Reprieve. 2 of them were our study participants, and then hopefully most of you remember the guy on the left there, Abe, who was our cab rep to the GCAB, as well as representative to our cab, and he had a heart attack, so he could not be a part of Reprieve. And then, of course, we lost him a year after this, almost to the day, when he had a second heart attack and passed away from that. So I just wanted to bring up Reprieve. It's so good to have these results. And it just made me sort of bittersweet recollection of how long it's been with this study, getting this study off the ground. And so I didn't know if anyone had anything they wanted to ask or say about these results.
I think for people living with HIV, that this is more monumental than anybody that doesn't have HIV and heart disease would think it is. And it amazes me that I remember those early days when it seemed like this wasn't going to go anywhere. And to have it finish this way is just astounding to me. And it's so nice to see that picture of Abe. Thank you.
Yeah, I mean, I couldn't help but think of Abe when I heard this news because, you know, he was 48 when he had his heart attack, you know, and his first heart attack, and I got to spend time with him in the hospital after that. And, you know, it was like, you know, like I'm happy Reprieve has shown this because I just keep on thinking of people like Abe who may not face death at 48. How many people can we help? I just you know, personally moved by that. Did anyone else have anything they want to share? All
It's a
right.
very nice remembrance of Abe.
Yeah.
I
And
miss him.
I miss him too. And if you notice, I have that hat that he's wearing. And I got that from his memorial. I wear it and I always think of him. Anyway, so
Gosh, it seems amazing that it took that long. I mean,
Yes.
that it, you know, I know you said that, but it doesn't seem like it would be 6 years ago.
yeah. Yeah. It seems like it was, you know, I mean, I just remember like, you know, all the work trying to get people into the study and to do community events. We, you know, we had Priscilla Shu come up and we did that event with Babes, you know, like really trying to focus on women and get the word out to the women with HIV as much. We got Kelly there, so that was great. You know, it just brought back lots of memories, but it seems like it took forever to get to these results. But to have a study with 7,000 people doesn't happen very quickly, you know, especially given that this is a treatment study of sorts. Anyway, I just wanted to let everyone know that. So I wanted to focus on long acting. This is what I was promising talking about, that we were talking about an HIV treatment that could be taken just twice a year. And to give full disclosure, I am going to be talking about this drug, Lenacapavir. We were hoping to do a study that was Gilead led for our clinic. We don't know if we've been accepted or not. Looks like we might not be, but I still wanted to focus on Lenacapavir just because I think it's one of those things, just like how Bill was pointing out that Reprieve is a big deal. I think this drug is going to be a big deal, and it sort of opens up a broader view of what treatment may look like in the near future for people, or could potentially look like. So you already know about Cabenuva, which is the two different drugs, cabotegravir and rilpivirine. You get one in each butt cheek, and you can get them every other month. And they're really starting to pump up the advertisements around this. You can watch a commercial on Cabenuva now. You may have even seen it being played. But remember, that requires someone else in a clinic to give you each of those shots. So it does change the paradigm of treatment, but it does mean that there might be more clinic visits for you, because you might now only have to come in twice a year, 3 times a year. This would be definitely coming in every other month. And so there's more clinic visits that would be involved with this. However, there's this new drug that I wanted to talk about. It's called Lenacapavir, and it is a long-acting HIV capsid inhibitor, which is a whole new class of HIV drug. And that's what makes it exciting. It's a capsid inhibitor because it interferes with the capsid formation. And you can see, it shows you where it comes in, the nuclear transport of the capsid into the cell, into the nucleus, and then you can see it interferes with the capsid assembly when it's coming out as a virus at the end. So it interferes in 3 different ways, which makes it a great new drug, and it's been shown to be pretty great. One of the things that makes it different than what we've been just talking about with Cabenuva is that people can give this to themselves, injections in the belly. And this is an example of what that looks like. So you don't have to go into the clinic for Lenacapavir to come in. So it has already been approved. It's called Sulenka, and it's out by Gilead. It is given by injections, and these are subcutaneous injections in the belly, and it is given in combination with other antiretroviral drugs. So this isn't like Cabenuva where the injection becomes the only treatment that you need. So this is, you're going to be taking other drugs as well with Lenacapavir, which might not make the dosing of it too exciting when people think about that. But for people who have resistance to various antiretroviral drugs, their virus is resistant. If they have multiple drug resistance, especially, this is a boon because it seems to be able to work with them. So people start with an oral dosing to establish the blood levels, and they describe this on the website as you take 2 different tablets on day 1 and 2, and then another tablet on day 8. And then on day 15, you get 2 injections. And then once you get those, then you go for 26 weeks, but no more than 28 weeks. And then you have to get another shot of that. So Lenacapavir remains in the body for about 9 months after the last dosing of it. So this is what the 2 dosings look like. People take the 2 pills and you get the dose shots on the first day, or you can be doing the first 2, day 1 and 2, and then another one on day 8, and then on day 15 get your shots and start that. But basically, once you get through that launching phase, that initiation phase, you are then basically on maintenance therapy, and you're just getting those shots every 6 months, and it's 2 shots. And you're also, remember, on some sort of other background regimen of antiretrovirals. You're not just taking Lenacapavir alone. And so there are some side effects, nausea and pain at the injection site for people. And there's some medicines that people shouldn't be using when they're using this drug as well. I just noticed St. John's wort, which just reminded me of some older times, how we had to watch out for St. John's wort. And so if you're taking that, Lenacapavir wouldn't be able to be used. You'd have to find a substitute for the St. John's wort. And there's also other sort of drug-drug interactions that are of concern. And I've noticed a bunch of these. There's some statins, there's sedatives and anticoagulants that are also concerned. And then also drugs that are used for erectile dysfunction can also be a concern for using this drug. So if you were going on this drug, of course, your doctor or your pharmacist would have to look out for those things for you. So
Last slide, Michael, I had a
sure.
question.
Let me go back. This one?
No, the one, the one,
Or that? Sure.
the one with the image of the, when you
Okay.
get shots.
Yep. Hold on. Oh, let me, where, here we go. There it is. Is it going back? There. This one? Oh,
Oops.
this one?
Yeah, this one.
Yes.
So I don't understand. It looks like in the bottom one on day 15 is when you're getting your first injections.
Yes.
But in the top, it looks like, oh, never mind. I see. I didn't see the other syringes. Okay, I got it.
Oh, yeah.
I haven't seen people do the bottom one, really. The one that I've seen talked about is the top one.
The top one, right. There,
And the
one
goal
other-
of those pills is really just to make sure, because it takes a little while for whenever you give an intramuscular injection, it takes a little bit of time to get the blood levels high enough of that medication. And so those kind of pills at the beginning are to just make sure that you get the blood levels of the medication nice and high so that there isn't like a gap in someone's ART while they're waiting for those levels to get absorbed, through the gluteal muscles and into the bloodstream.
Right. And so these came from the website that's dedicated to Sulenka from Gilead. So that's where I picked these up. And I think there is the bottom one, I think we'll see in a clinical trial that was the rhythm that they used, I think. But yeah, I think the top one is more what we're seeing people use. But both of them were there. So going through this. So the first study that really showed that this works for multi-drug resistant HIV was the Capella study. And this was involving people who had very few treatment options left. And so they got subcutaneous Lenacapavir, and they got 3 doses, one at the beginning, in the middle, and at the end. So you can just imagine at the beginning of the study, middle of the study, which was 6 months, and at the end, because it was a year long. Everyone had to have at least over 400 copy viral load, and they had to be HIV resistant to at least 2 drugs from 3 out of the 4 commonly used classes. So whether it was a nucleoside reverse transcriptase inhibitor, an NRTI or an NNRTI, or a protease inhibitor or an integrase inhibitor, they had to have at least 2 drugs out of the 3 of the drugs that they would be taking have some sort of resistance to them. So they enrolled 72 people in this study. The average age was 52, and people generally had HIV for about 24 years. 25% of these people were women, and at screening, half of the people had a viral load that was over 32,000 copies. And half of them had a CD4 count that was below 150, the lowest being 3. So they had a CD4 count of 3. And the resistance to at least 2 of the drugs, almost everybody universally had 2 drugs, the NNRT in one of the NRTI or NNRTI classes. 81% of them had a resistance to PIs, and 69% had resistance to INSTIs, or the integrase inhibitors. And by the halfway through the study at week 26, 81% of them had viral loads that got below 50. 89% of them got below 400. And so when you're talking about half of the people starting out with 32,000 as their viral load, you can see in half a year, this helped them finally bring down their viral loads. And remember, these are people who have multi-drug resistant versions of the virus. So there were 11 people who didn't get below 400 by week 26. And they did manage to get everyone except one person to be virally suppressed. 4 of these 11 people had a resistance to Lenacapavir. 3 of them got back their viral suppression. 2 of them didn't require any of their changes to the other ART. 1 of them did, but all of them remained on Lenacapavir. The one participant who never achieved viral suppression did have a fold or a fall of 50-fold in their viral load. So it did seem to do some good in terms of lowering their viral load, even if they didn't become suppressed. And people, on average, the average CD4 count went from 143 to 224 6 months later. And the proportion of the CD4 counts that fell below 50 went from about 22% at the beginning of the study to 0%. So they didn't have people who had low CD4s after taking lenacapavir. So it showed that there was some immunological boost, which was also valuable for these people. And then the study was then written up and published in the New England Journal of Medicine. There was another study, and this one was in what we call treatment naive people, or people who are starting HIV treatment. It was 182 people who are new to treatment. They had CD4 counts over 200. 15% of them had a viral load over 100,000, and the average age was 29, but I think it went from 19 to 72 in terms of the range that they had. 77% were women and 52% were Black. There were 3 lenacapavir groups, and then there was a comparator group. The comparator group basically took what is Biktarvy, bictegravir, FTC, and TAF. And then the lenacapavir groups, there was one that just used lenacapavir orally and did that with bictegravir and TAF. And so that was a 3-drug regimen using lenacapavir. And then they had two 2-drug regimens. One was lenacapavir with TAF, and the other one was lenacapavir with bictegravir. And so after a year, you can see that they had efficacy rates that were pretty good. So the one that was the comparator had 92%, and then the one that was using lenacapavir orally with bictegravir and TAF was 90%, and then lenacapavir with TAF alone, 85%, and lenacapavir with bictegravir, 85%. And so these results were also exciting, and they're going to be looking forward to more research looking at this as a treatment for people who haven't had treatment before this time. But again, notice that we're talking about people still having to take other oral ART. And so that's the concern here. Like, you're still going to be taking a daily oral pill, even if you're getting lenacapavir as a shot every 6 months. So this also, if you remember, just back when we talked about CROI 2 months ago, I was talking about this study, which was talked about that they did lenacapavir, and instead of having ART, they used 2 bNAbs. And so the 2 bNAbs dosed every 6 months in people with HIV, and the results looked good. And this was leading to a phase 2 study, which was my lead into the study we were hoping to do here, which is basically a study of lenacapavir with these 2 bNAbs in people who are suppressed on ART. And so this is the actual clinicaltrials.gov number for it. It's a phase 2 study. It would be open label, meaning everyone would know what they are getting, but they would be randomized. And so the whole idea was to randomize people to one of 3 groups. So the first group would start off with oral lenacapavir, and then they would also get the subcutaneous shots, and then teropavimab or TAB or zinlirvimab or ZAB, and that was going to be on the first day. And then on the second day, you would administer to yourself lenacapavir oral, and then you would end up with your last treatment regimen would basically be the subcutaneous lenacapavir plus these 2 bNAbs every 6 months. So group 2 is doing a similar thing with that. They would just have different doses, and I didn't indicate those. I apologize, I forgot that part, but basically different levels of the bNAbs. And then group 3 would be basically on the oral ART that you are already on and just staying on for the first year that way. So no changes for that group. So they would be randomized to one of these 3 groups. And then after 52 weeks, after the first year, if you're undetectable in group 1 and 2, you get the choice to extend into another phase and basically get the treatment regimen of every 6 months for approximately 5 years. And for group 3, who is on the oral ART, where they had no change, if they are undetectable after that first year, they would also get that option, and they would be following the treatment dosing regimen of group 1, and they would get to stay on that for 5 years as well. And this study was looking for people who would be from 18 to 65 years old, unstable or oral ART. They had no documented historical resistance to their regimen. They're undetectable with copies below 50 for at least 1 year preceding their screening to this. They would be tested to make sure that they had a sensitivity to both TAB and ZAB, and they would have to have a CD4 count of at least 200. There were some exclusion criteria, and the exclusion criteria would be if you had a comorbid condition that required ongoing immunosuppression, if you had evidence of being infected with hepatitis C. Now, you could have had a prior infection and it could have cleared either spontaneously or with treatment, and that would be acceptable. But you couldn't currently have evidence of infection with hepatitis C, nor with hepatitis B. And they say not having a history of opportunistic infections or illnesses that are indicative of stage 3 HIV disease. And of course, there were other protocol-defined exclusion criteria that they didn't put in the clinicaltrials.gov for you to see there. But that gives you the idea of what was the inclusion and exclusion. Now, the last thing may bring up some questions to you. What is stage 3 HIV disease? Any ideas? Well, I looked it up a little bit because I was confused and I didn't know what that meant. And I was like, what are they talking about? What's this stage 3 versus stage what? So just to review this is from the CDC. A confirmed case of HIV is classified in one of 5 stages, and it's basically 0, 1, 2, 3, or unknown. So if there's a negative test within 6 months of your first HIV diagnosis, that's how you are considered stage 0. And you're in stage 0 until 6 months after that diagnosis. And then you go into one of the other stages. And so the other stages are determined by the CD4 count. And so you can see here, stage 1 is when you have greater than or equal to 500 CD4 count. Stage 2 is when you're between 200 and 499. Stage 3 is when you are less than 200. And then the unknown is when there is no CD4 count on hand that they can use to refer to. So that's when you would get the unknown. So stage 3, if you don't recognize that, that's actually how we define AIDS. And so what that quality was saying is that not having any opportunistic infections or illnesses that are commonly associated with an AIDS diagnosis. So that was one of the other exclusion criteria. I know that was a long-winded explanation, but I just figured I would share that because it was news to me to learn what the actual stages of HIV were. So again, I don't know if we're doing this study, if we'll be chosen, if we'll be selected. Chances are we won't be, but I wanted to give that to you as an idea of the future of that. And I wanted to now open it up to any questions that you may have about lenacapavir or lenacapavir, the study that I just presented.
Before we open it up to, I just wanted to say, yeah, I'm trying hard to talk with different industry groups to see if we can bring on a study like this or similar to this. And so part of, I think in presenting the study, whether or not we have the chance to do this one, I think there are potentially a lot of studies coming down the pike to look at other either known or novel long-acting agents, oftentimes in combination with broadly neutralizing antibodies that stretch out the treatment arm. So maybe the discussion can also be a little bit more broad towards like a study similar to this, like what's the appetite here for something similar to this, if not this study, and potentially by a different sponsor.
Exactly. How are you feeling about long-acting, and by long-acting, longer-acting, we could even say, treatments? What are your thoughts on those? Go ahead, Bill, Freshwater.
Yeah, I'll jump in. I'm confused as to what the benefit or why I would want to take this lenacapavir if I have to still continue to take daily oral ART. I mean, for me, you know, I'm interested in stopping taking daily art, but I don't understand why. What's the benefit of this one if I still have to take a pill every day?
That's a really good question. So right now, the reason why it's approved is for people who have a lot of resistant virus. And so it helps support a treatment regimen similar to like many people may have been on Fusion or other things in the past. Also called T20 to kind of help when they have resistance to multiple drug classes. So that's the current FDA approval for it, is in support of another set of drugs for which there aren't enough oral medication classes. But the way that we're looking at it, both in this particular Gilead study and the sort of imagine other long-acting studies, would be to combine it in different long-acting combinations, either with broadly neutralizing antibodies or potentially combinations of different other long-acting injectable agents, injectable or infused, meaning like an IV bag, to eliminate the need to have that oral component to it. So the current FDA indication is different from sort of imagine a future of it as part of a solely long-acting injectable combination.
Right. And so I guess the question is, Bill, would you be interested in a study that might be giving you a regimen that is every 6 months in terms of lenacapavir and 2 bNAbs every 6 months?
So yes, I would be interested in, if I would not be interested in taking the injectable plus having to still take my pills. But
Right.
if I could do something where I had to take a couple pills and get an injection, and what was very important for me, and I'm very glad you covered in there, my fear with these has always been, when does it wear off? I mean, how, I know, somebody who's taken pills since AZT, I mean,
Right.
I know that as long as I'm taking my pills every day, I'm covered. And my fear with these is always, when does it wear out? What is my window of, okay, it's 6 months, but, is it 5 months and 2 weeks? Or, so it was good that the slide that you showed, that showed it was 9 months, makes me more comfortable. So yes, I would be comfortable, because, when I went on a study that had an ATI, it was delightful, quite frankly, to not take pills every day. And I would like to get back to that, to that. And, and I am very comfortable with self-injecting. I mean, once they teach you how to do it, that would be very cool. But I would not be comfortable doing a study for myself that I still had to take daily pills and an injectable, which is a long answer to your question. But the short answer is yes, it would be. I would be very excited about it.
No, thank you for sharing all that. I think I appreciate the long answer.
Yeah.
Details. How do other people feel? Do you feel like that would be something that people would like to see in terms of our forward direction in this research? Would you like to see us having these options for people to enroll in?
Michael, can I ask a question
Sure.
that deals with actually the Reprieve study? Do
Sure.
you think taking a statin every day is going to become part of standard of care? Because Bill's answer about taking other pills, and if you end up having to take a statin, you're taking a pill.
That's true.
So that's a question.
It's a great way to relate it. So even if we can go to 6 months treatment with the HIV treatment, how many people are on other pills for other reasons or other comorbidities that they have, whether it's a statin for heart disease or a diabetes medicine? Bill, do you have your hand again raised? I see Freshwater.
Yeah, I do, because I take a statin every day, and I take valcyclovir every day for herpes. And I'm trying to. So I guess, I mean, that's a really good point. And I guess in my mind, I see a difference between, I'm an old guy and all old people take pills. And I kind of can separate them from my HIV meds. And my HIV meds, because I think that, again, for me, somebody who's been on them for a long time and knows of of I don't really see any side effects with my statin. I mean, I take a statin, I don't take a statin. I don't get sick, I don't feel nauseous. It doesn't, but HIV meds have been are kind of harsh sometimes. So I can, in my mind, for me, I separate them, and I don't see. I know it's the same thing, but I can sort of separate them in my head.
No, that's really helpful.
I guess that's just me. Yeah.
Bill, I think that's really helpful.
And I see that Manuel wrote in the chat that he would not participate if he had to still take his current ART plus an injection plus IV antibodies. It would seem too complex for long acting. He would participate once the progress came to be that it was safe to do injections alone.
Okay. So to clarify, none of these studies that we propose are to use it as the current FDA approval.
Right.
With daily ARTs. So the current way that it is used essentially is for people who don't have enough oral pill options and need a third or fourth jug to prop up their pills in order to get to suppression that way. So all of these studies that we're talking about, either a real or future potential study, are looking at all combo long-acting treatments without daily oral pills.
Right.
This one, because it's randomized, one could be randomized to an arm in which there is no lenacapavir or BNABs, and one remains on their oral pills as like a control group.
Right. And that would be for the first year, and then you would get the option to join in.
Yeah. So it's confusing because like the way it's FDA approved right now is not how it'd be used for these studies.
Yes, and I should have made that clear that Sulenka was approved, but it was for that multi-drug resistance situation that we started off with, which was exciting in and of itself, especially for those people who had multi-drug resistant HIV. But that kind of probably confused us in terms of what we're talking about in terms of the long-acting research and looking at these as treatments. So as Rachel just reminded us, we're not talking about taking your current ART every day and then using the lenacapavir. We're talking about lenacapavir and some other form of BNABs or something that would help you go for 6-month treatments every 6 months.
Is the phase 2 study that they want to bring to Seattle, is that going to be focused on people who don't respond don't respond to the current regime of medications? Or is it going to be all inclusive?
No, it's focused on people here. Let me go back. It's focused on people who are on stable antiretroviral therapy. So it would be not those people who are having drug resistant. This is for people who are taking successfully antiretroviral therapy and have achieved viral suppression for at least a year.
I should say also the other sort of potential study that I have in my mind for something that several folks at the ACTG are working on, and we've sort of talked about in terms of Cabenuva, is the real unmet need for folks who can't take daily ART for whatever reason, and not necessarily due to resistance, but just can't make it happen. Or have, intolerance to the medications or things like that. And so there is a real strong effort, not necessarily in partnership with some of these pharmaceutical companies, but to try to get trials going for the unmet need for people who are unsuppressed and have had challenges taking their ART over the years. So that is kind of along the lines of Latitude, but Latitude is Cabenuva and is randomized. So, the possibility of other regimens, some of which include the possibility of lenacapavir for folks that haven't been able to take oral medications easily.
Right.
Well, I've told you over 100 times, Michael, that, I take so many other pills a day. I take 28 pills a day. Removing 3 really wouldn't make that much of a difference to me.
Right.
So I'm in that state of mind where I think if it ain't broke, don't fix it.
But Bill, do you think other people would be interested in that?
Oh, I absolutely do. I think this, you know, uh, before they reach my stage, which I would guess would have been about my 50s when pills really just, it seemed like every time I turned around, that was getting a new prescription. That this would really be something that was appealing, because that's the biggest part of becoming HIV positive. And when I do my talks, I tell them, you know, coming down with HIV absolutely changes your life. You have to take medications every day, and we're not a society that's used to taking medications every day.
Valerie, you have your hand raised.
Hi, everyone. Yes, I do. I have been, since the first day of heart, I've been taking ARVs, and I take a lot of other pills. I'm probably in the high 20 range as well, but I would do this if it was, just one injection every 6 months. I don't know why. And I've been trying to figure this out for a long time because I'm taking pills anyway, but it excites me to think about only having to get an injection every 6 months.
Mm.
I know. I can't figure it out.
No, like I understand. I mean, like, yeah, like it might not be, I think it's about just making your HIV treatment, like, even though you have other treatments for other things, but like your HIV treatment, shrinking that a little bit like that, like, just, I don't know. I think there's symbolic meaning to it. It's an achievement, especially if you started out taking pills every day. To go to something that's even every month or every other month or every 6 months, I think is just feeling like a level of achievement, like even if you have other pills that every day you still have to take. At least that's how I would feel.
Yeah, absolutely. I agree. And it's just, I don't know. I think also too, no, not really. Yeah. I really don't know, but yeah, I'd be the first one on board for every 6 months.
Awesome. And so there's a question in the chat. Does anyone know if polypharmacy will eventually go into long-acting injections in the future? I don't know the answer to that. I'm sure since this is all still new, we need to work on that. Like,
Manuela, are you talking about like for other conditions besides HIV, or are you talking about like multiple ART meds combined into one injection?
No, I think for like other, so you know how like Bill or Valerie were saying that they take 20 plus pills per day for other conditions, would something similar like long-acting injections be for something like that?
I think for some conditions, I think there's some that will never be that way. For example, like blood pressure or heart pills, just because those are things that you can imagine if someone got a long-acting injection of blood pressure medication and then something changed, it could be dangerously high or dangerously low. The ones that I know of that already exist would be naltrexone, which helps people with alcohol and other cravings. Contraception, of course, has been around for a long time. And then there are some psychiatric medications that are available in long-acting form. But speaking of combination antiretroviral therapy, is it now maybe a moment of time to just also remind folks that we are trying to recruit for our triple ART nanoparticle first in human study. So it'll be for people without HIV testing this really cool therapy. So I don't know, Michael, if you have any materials
Yeah.
at the end of this presentation too, but to just
Yeah,
remember to
no,
tell
I
folks
was
in the
gonna,
community to spread the
yeah,
word.
I was going to remind people about that. If you remember last month, we announced that our first in human trial was launching and looking for people who were negative, who are otherwise healthy, and looking to help us advance that research. The whole idea is to have subcutaneous shots that people will be able to give to themselves, but it would be of the traditional oral ART regimens, but this would be a version where you could take it like every 3 weeks. So you would have all of your ART in one shot that you would be able to give to yourself is the whole goal. So that's also research that we're doing here. TLC ART, and I'll remind people at the end as well with the website on that. But I did have one other last study to look at. And this was a study that came up about HIV remission, or at least a study that's related to remission and the attempts to cure HIV, HTX 1004, and it's a phase 1, phase 2 study of some vaccines plus broadly neutralizing antibodies, and it involves a treatment interruption. So some background, this is a study that catchy title, yes. This is being conducted at Beth Israel Deaconess Medical Center, and you might recognize two of the names who are leading this, Boris Ulig and Dan Baruch. It's a randomized placebo-controlled double-blind phase 1/2A study. They're experiencing slow enrollment, and to just show you how slow it is, they didn't enroll their first, they were ready to go in January, but they didn't enroll their first patient until October. And they've now reported that they have about 3 people enrolled, 1 pending. And so they were doing a survey of ACTG sites to determine whether we would like to be interested in this study and how many participants we think we might be able to enroll. So I wanted to kind of review this with you all to get some idea. So this is an investigative study looking at the safety, tolerability, immunogenicity, and the exploratory efficacy of a vaccine regimen. And there's 2 vaccines, a prime and the boost. And that boost, the MVA Bavarian Nordic, is the first in human part of this study. And then they're combining it with 3 neutralizing antibodies, PGT101, PGDM 1400, and VRC07 523LS. And this would be a study done in people who are already on suppressive ART. They're looking for 36 people that would be randomized in a 1:1:1 ratio into 3 groups, which would be either to get the vaccines and the BNABs, to get the vaccines and just placebos instead of the BNABs, and to get placebos versus the vaccines plus the BNABs. So those are the 3 groups. And so this is what it would look like to give you an idea of the study design. The group 1, which is above that box right here, you can see with the red and the orange, those are the people who are getting both the vaccines and the broadly neutralizing antibodies. Group 2 would be having the broadly neutralizing antibodies as placebos, and group 3 is the placebo group with the vaccines and getting the BNABs. So you can see how basically day 0, they start after screening, they get the shot. So the first 2 groups would get the shot, the third one gets the placebo, and then at week 12 there's a booster shot, and then at week 24 they would get their BNABs and then, or the placebo, and then they're put on a washout period and they go onto an ATI until there is rebound. And the whole point is to see how long they can go before there is a rebound. So to go through all of that again, so the first stage, they're going to have a large blood draw. It's an optional leukapheresis. They have a peripheral lymph node fine needle aspiration, which is optional. And then you get the vaccine at week 0, and then you get the placebo at week 12. And then stage 2 is basically starting on until you're staying on your suppressive ART until week 24, which is 12 weeks after your second vaccination. And then participants who are eligible to start the ATI will receive a single intravenous dose of the 3 BNABs or a placebo at week 24. And then 2 days after you get those BNABs, you stop your ART. And then people will get a second dose of just the PTG PGT 101 and PGDM 1400 or placebo at week 28, because those two have a shorter half-life than the VRC07 523LS, which would last longer. And so to make sure that the BNAbs all wash out at the same time, they're giving you a second dose of those at week 28. So that's stage 2. And then there's the washout period, where after your final infusion at week 28, participants basically get a washout period. And this is to allow the concentrations to decay sufficiently low levels so as to not affect viremia during the stage 3 ATI when you're going to be monitored for viral rebound. The expected washout period is 20 weeks. And so then if they go on to the ATI, they can continue, or if their restart criteria, which I'll go through in a moment, they continue with the ATI. If the restart criteria are met, they will start their ART again, or until if they reach week 72. And then participants will be followed every 2 weeks until they have levels of confirmed viral loads, and then every 8 weeks until the end of the study. During these follow-up visits, they're going to have lots of assessments, including monitoring their HIV RNA and the CD4 counts. So the restart criteria you can see here is having viral RNA that is at 100 or higher for 4 consecutive weeks or greater, and is not dropped in 0.2 logs from the previous week, and the plasma HIV and RNA levels at 200 or higher for 12 consecutive weeks. Any sign of symptoms attributable to HIV rebound other than mild. 2 consecutive CD4 counts that are less than 350 at least 2 weeks apart, or if it shows 15% of the CD4 there. You have self-reported condomless anal or vaginal sex with a partner who is HIV uninfected or serostatus unknown and not on PrEP. Bacterial STIs during the treatment interruption will trigger additional educational mitigation effort and consideration for reinitiation of ART. If someone develops clinical progression to the stage 3 HIV disease, which we just covered earlier, if they become pregnant, or if they request to start ART, or if there's other medically necessary reasons that their provider thinks that they should restart ART. And so who are they looking for in this study is people who are 18 or greater, up to 70 years old, on ART for at least a year, and they have an undetectable viral load for at least that year. They have a CD4 count that is greater than 450 cells, no history of AIDS-defining illnesses within 10 years prior to screening, or having a nadir, the lowest point of your CD4 count going below 200. You cannot be receiving any therapeutic HIV vaccine or monoclonal antibody therapy. And there are other criteria which they will go into. They just make you have to look it up in their Lancet article, which I didn't go through for all of this. Also, this study...
Can I ask a question here?
Sure, go ahead.
When they say AIDS-defining illness, are they talking about the standard illnesses that people with AIDS developed in the 80s and 90s?
Yes.
Or does that encompass, like when I came down with lymphoma, they told me that it was AIDS related. Is lymphoma considered an AIDS defining illness?
Depends on what kind of lymphoma.
Non-Hodgkin's.
Yeah, that is considered to be AIDS defining.
Whereas Hodgkin's disease is not.
That's a whole other topic on the silliness, a little bit of those designations and how they're a little bit historically inaccurate and currently inaccurate. But
well, the reason I brought up that question was a defining illness was I'm finding out from the stages that Michael did that I never knew stages existed within the AIDS diagnosis. And so when I saw AIDS defining illness, I said, well, what does that encompass? Does that encompass everything, or is it select?
Okay.
That's the only
so
reason they
the
asked
stages, I actually don't really use stage anymore. It's really just by CD4 count. So it's not those stages are not within AIDS. It's essentially CD4 count
Mhm.
levels, with stage 3 being equivalent to a CD4 count below 200.
Those stages are ancient.
They're
Ancient.
ancient. I
They're
know.
really ancient.
And especially because stages can go backwards
Mhm.
too, so that somebody can start AOT and go and then go up by stages.
Right.
Which is why they
Um,
sort of lost favor.
Yeah.
Yeah.
Anyways, also because it matters so much less, right, when people are undetectable and doing well, other than what somebody's lowest ever was. I think the other comment I'd have to look up on the other inclusion and exclusion criteria, because I saw the heading of this, but I think it was not super inclusive of a lot of other medications and other
Mhm.
medications. I was looking at this and I was a little bit worried in terms of bringing it on for our site about the number of people that would
Be able to-
meet criteria for like non-HIV reasons, just
Right.
kind of like what we were talking about, people who have a lot of other conditions. But let me pull up that Lancet paper
Okay.
and see if I can find more information on it,
Yeah.
because I did see more.
So anyway, while she's doing that, I wanted to just point out also, people need to undergo an ophthalmological exam at the beginning, at the end of the study. And that's because some broadly neutralizing antibodies create some retinal damage or some retinal problems. And so they want to make sure they do an exam at the beginning, at the end of the study. Now, these 3 that they've selected here are not known to do that, but still they're being safe and they're looking at that just to make sure that they have a ophthalmological exam before the study and before they're given the BNABs. And then so if something does occur, they'll be able to have a test to measure it against. So that's something else that was coming through this study. And so what do you guys think of this as a study, or do you have any other questions you want to ask? How invasive is that eye exam? Manuel, people, it's a common exam. It's not very invasive at all, is what they
Do
say.
people have to get their eyes dilated?
That I don't know. I'm
If
not.
it's a slit lamp, it's a slit lamp exam.
Yeah.
Which means that someone does have to get their eyes dilated, but it's not invasive, as in the term slit means you look through a tiny bright light slit. They don't put a slit in your eye.
Yeah. So, but there.
I've had it done before several times.
So does that answer you, Manuel?
Yeah, it does. Thank you. I think I probably also had these exams, but never heard that phrase
Yeah.
before.
Yeah, it is kind of interesting. I never heard of it either. So these guys were asking the ACTG to help with the recruitment for this study. And so we were just wondering what you all think. Would this be something that you think people would want to get involved with? You know, it's not an ACTG study yet, in other words. And that's why we're turning it to you to see what you think.
And I think the intention is for it to never be an ACTG study,
Right.
but for ACTG sites to participate individually if they so chose.
Right. It's helping recruit their study.
Well, I think the problem I'm having at the moment is I'm trying to figure out if it's me, am I having a bad day, or am I just not understanding?
Understanding.
Um,
Go ahead.
I You know, when you were talking about the the body of the study, I didn't understand a single word you said. There were so many numbers, so many
Yeah.
jargon, so much, you know, it just, and it's a lot of information to take within 5 minutes.
No, it is. So here, let me go back. So like, I'm going to go back to the diagram because maybe that'll be the easiest. Now, why did one get, okay, I had to go back this way. It won't let me go back all the way. Here we go. Let's play from this side. So you can see the diagram here. So you can see, like, if you look down here at the bottom where the weeks are, week 0 is the start of the study, and that's when people would get the first vaccination or the placebo for the vaccination. So those 2 red arrows along day 0 up top, those are the vaccinations. And then the person who's in group 3 would just get the placebo. And then 12 weeks later, they get the booster shot, the other vaccine. So we're starting off, they're staying on their ART and they're getting 2 vaccines, a vaccine and a booster shot. And then at the end of 24 weeks or half a year, they're going to get a BNAB, 3 BNABs, or a placebo, depending on what arm they're in. And then at week 28, they get a second dose of the 2 BNABs or placebo. And 2 days after they get the first BNABs, they start their ATI. So the ATI starts then, and then they have a washout period, and then they're going to monitor for 72 weeks, waiting to see if people have a rebound. And if not, people will restart at 72 weeks. Does that help, Bill?
Well,
So
is
it,
this
Michael,
the
is,
second study?
Yes.
This, I was talking about the third study you brought up.
The previous study,
Oh, the one after this.
no, this is the one we're talking about now.
It's all the same.
Yeah, this is the vaccines and placebos.
Oh, I thought we were in the third study now.
No, sorry, this is the same study. This is the HTX.
That's where my confusion.
Okay, got it.
so this is trying to look at whether adding BNABs to a vaccine is useful in suppressing HIV. Is that the idea?
Yeah, therapeutic vaccine alone or therapeutic vaccine with
Being
BNAB
plus- Right.
or BNAB alone.
Right. And there's all this previous research in the vaccines having some therapeutic effect in terms of how long it can delay viral rebound, or the vaccinal effect that it can have, or the BNABs can have. And so they're looking at this as they expect people will rebound. They're just wondering how long and what sort of mechanisms they can capture in terms of what helps people delay that for as long as possible. Valerie, you had your hand up.
I do. I would do this. Also, I basically fantasize about treatment interruptions. And so I would definitely be on board for this. And I don't have a problem with adherence. I mean, I just can't figure me out. But yeah, I would do this in a heartbeat.
Wow. That's great to hear. Lori, you had your hand up as well.
Yeah, you probably talked about this. I have got like COVID brain going on today, I think. Seriously. So how frequently are people monitored for rebound, and what are the restart criteria?
Yep. Hold on. I'll go to that slide. Whoops. Let me close
Okay.
this. All right.
And so the goal is really looking at the vaccine and the BNABs in the background of having suppressive art.
Yes.
And seeing how much additive effect there is for being able to go off art.
Yes.
So people would not be on ART during this part of the study, whether getting vaccinated and or BNABs.
Right.
Right. And so every 2
Every
weeks.
2 weeks.
And then these are the restart criteria.
And what is Oh, wait, let me just see. I wanted to see the stuff around protecting against transmission.
Yeah. So basically, if someone reports condomless anal or vaginal sex with a partner who's
Yeah, okay,
uninfected,
I see it.
yeah. And then, like, or if they're
Okay.
diagnosed with syphilis, gonorrhea, chlamydia,
I'm
that
not finding the rest of this eligibility criteria.
in there,
Michael, can you flip back to the slide where what's this with the citation where it's at Lancet HIV 2019?
oh, that was
Because it's not under Boris's name. Oh, it is. Jules. Okay, maybe it is.
that's how they put it. And this is their slide. I got this from the presentation they did for the TSG.
Okay, I believe you. Let me try again.
So maybe they got it wrong if you can't find it.
No,
No.
no, I found.
Oh, cool.
When I type things correctly, it's easier to find them.
Oh, well, they didn't type his name correctly. It's Drew Leg. It should be with an E there. So that's also the problem.
Yeah, I had thought it was. I thought his name had an E in it, but
It
it
did.
is. It in this citation. It's because it's Joelg is how I think he says his name.
Right. Right. So what are other people's thoughts? Anything else you want to share about this study? We're almost at time, so how about if I at least do this? I'm going to stop sharing for now so I can take the last few moments to look. Hi, Bill. I see your face.
Well, we already have somebody who expressed interest in participating. That should
Yeah.
mean something.
Yeah, that's good. Yeah, so like it's just wanting to run these things by you all because I think it's important to hear your thoughts, and it's not even just about these specific studies that we presented, but just your feelings around studies like this, if we should continue to try to do things like that. Go ahead, Bill, Freshwater.
Oops, there we go. My 2 points would be, one, I'm glad to see that it's not cut off at 65, that it goes to 70, because I'm 66, so I think that's a good thing. On the negative side, I think testing every 2 weeks is that would give me a little bit of concern. I would be more comfortable with a weekly test, and I would be really comfortable with, as I always point out, some form of a home test, so that you don't have to schlep into some clinic. But I think for me, 2 weeks is seriously that would be a little bit, I think, a deal breaker for me. It's just a little bit too long for me to, when you're doing so many new and different things, I think 2 weeks is a little too tough. Thank you.
Cool. No, thank you for sharing that. I wonder too. Like I would feel like every 2 weeks is a little bit too long because like it's a long enough time that your viral load could go from 0 to really high, like higher than knowing that's happening, like where but I'd be the type of person that I'd probably want to see it every day if I could, like I want to see when it would just be happening. Like I would just want to know that as much as possible, because I'd be worried about letting it go on for too long. But one of the things they want to see in this study is if even when your viral load comes back, does it reset your set point to a lower? Does it help hold it down lower? So they want to give you a chance to be viremic for a little bit just to see what effects either the vaccines or the bnabs would have. So I guess to do a study like this, you'd have to be willing to face the idea that you might have some viremia that you might not be ready for.
Can I share they from this paper, this is like a kind of expert, not entirely consensus statement, but it's a the paper is called Recommendations for an Analytical Treatment Interruptions in HIV Research. It is report of a consensus meeting. So it's a bunch of experts in the field who talked about who should or should not be eligible in these studies. They don't actually give eligibility criteria in this paper. They talk about generalities. They essentially said anybody with active cancer or a history of cancer should be excluded because they don't want to sort of increase somebody's risk of having that come back. The consensus that there was no single right population, that there should be sex, gender, racial, and ethnic equity in these studies. They talk about the complexity of including children, but I think a little bit more concretely, this paper says people with co-infections, so hepatitis B or hepatitis C, active tuberculosis should be excluded, people with cancer, people with neurologic concerns. They give a variety of neurologic concerns. Anybody with HIV resistance for whom it might be difficult to find a treatment. For example, if there was an interruption and they came back onto ART, there weren't a lot of good options. People with high risk for cardiovascular disease, since we know that being off of ART can increase cardiovascular risk. People with a history of any AIDS-defining illness or CD4 below 200, pregnancy, breastfeeding, liver disease, and kidney disease. So these are kind of like these big general groups. I mean, I think essentially they're, and then anybody who is sort of at risk of HIV transmission because they're either not with partners who are on PrEP or positive, or you know, with other kind of backup mechanisms in the case that they became viremic. So it's kind of a lot.
So it sounds like a lot. Sounds like they really want sort of healthy volunteers with HIV.
Yeah.
Who are celibate or having sex with people who protect themselves. That's a big ask.
Yeah.
I feel like the energy in the Zoom room just dropped.
Yeah.
Sorry.
It's okay.
I read that, and I also when I read the protocol, they didn't exactly say that in there, but I feel like I read it somewhere else about this protocol, and I worried about that. And I also just like wanted to acknowledge that they don't use people first language in some places, and so in the eligibility criteria, you may have noticed that too. And that didn't hit quite right, but it's, even though it's collaborators in the ACTG. So I just want to acknowledge that, and you know.
Yeah, no.
Well, and if they're having a slow go of it, it's now you see why.
Yeah, that's what I was going to say. It seems like there's a reason why the enrollment has been slow. So
that was my thought as well. You know, if it took them 10 months to get their first participant, why was that? Why is that common in studies where there are some studies that take forever to get participants that I don't know about?
It can be, but I think when it happens like that, it is a sign that there might be some sort of criteria or maybe a design flaw that is knocking people out from consideration. So I think it's a symptom. It doesn't necessarily mean there's something drastically wrong with the study, but I think it shows. I mean, it could also just be that they weren't doing outreach around the study. You know, just who knows? I didn't ask any questions. I didn't get a chance to ask any questions about why it was taking so long and why they think the enrollment was so slow. And if it's slow for them, why wouldn't it be slow for us, is my thought.
Yeah.
But I think
the other thing to note is that the January date is when they got their IND, and as we know from trying to start up the TLC ART 101 study, and other things, right? The date that you get the IND is sort of the date that you step on the gas, and then there's a bunch of final things that need to get finished before you actually can start recruiting people. And then once you can start recruiting, then you have to like open the pipeline and then start enrolling. So I guess that kind of brings us back around to that very same study that has now been open for 1 month without a successful enrollment. And please spread the good word.
Yes, we will. And so I wanted to wrap up our meeting tonight since we're at time over a little bit. And I wanted to thank you all for participating, for sharing your voices, and for voting. And so we will be taking what you've shared about the votes. I'll make sure I get those to you, Manuel, so you can then, if you can want to send them on to Orbit and to everybody, that'll be great. And we'll just end it here. So thank you very much for your participation. Good to see your faces, and good to hear your voices. Take care and be well. Enjoy your concert tonight, Rachel.
Take care.
Bye.
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 Cheers. Bye, everyone.
Bye, everyone. Oh my God.